at the end of the discussion, and I'll request everybody to put their questions in the chat box. Dr. Dasgupta, please, you can start. Thank you very much.
Good evening, and is it all participants are from Bangladesh or any other international non-Bengali speaker?
Yes, there are non-Bengali speakers also. I have my friend from Iran here, Dr. Popa.
All right, okay. Good. Yeah, I will only stick to English then. So, welcome all. Hope you like it. At the end of the day, it may be for someone a long day. There are a lot of slides. The PowerPoint is not a very good quality because I did it when I was doing a long case. So I apologize for that. So there is mix of lot of PowerPoint slides I copy pasted from my other lectures. So I've been introduced. So I started my journey from Calcutta Medical College, and I work now in George Eliot Hospital. And coincidentally, both have the same address. Both have College Street in their address. So I'm going to so the whole purpose of labor analgesia is that a woman should only feel is joy and happiness. I will straight away go to the anatomy and physiology. What are the recent thinkings and what things we don't do it properly? So I will address it as three questions. Where from the pain is coming from? And is pain bad in labor? And what are the analgesic options we will discuss? The pain, it comes because there are two stages of labor. Stage one, it is purely uterine contraction with cervical dilatation. In this one, it is mostly through the C fibers, which are unmyelinated fibers. A little bit of contribution comes from A delta. It is because of the ischemic products. Because of the myometrial contraction, the blood flow ceases and the myometrium becomes ischemic. And then these anoxic products then irritate the nerve endings, which causes the pain in the first stage of labor. This is very, very poorly localized. It can be in the tummy, it can be in the back, it can be in the thighs even. The stage two is somatic pain. That means it is very, very sharp. It is mostly through A delta, and it only involves the S2, 3, 4 nerve roots. It has also contractions going on. So it is a combination of both visceral and somatic, but somatic is of more preponderance. So that has implication on what sort of painkillers would you give? Like first stage, because it's a sympathetic pain, it is poorly localized. You don't need local anesthetic. You can just use a fentanyl and that should take care of the pain, because for the sympathetic pain, the best is to give a low dose opioid. As the pain progresses into the second stage, it becomes somatic, where you will need local anesthetic, especially to block the sacral segments. So as you can see from the next picture, that as the labor progresses, the more and more the pain gets concentrated towards the sacral or the perineal areas, the sacral dermatomes. So to summarize this thing, I just put a table that these are the difference between the contraction pain and the delivery pain, or the first stage and the second stage. The first stage, as I told, it's a visceral, it's a slow transmission, and it is referred to everywhere in the body, towards the lower part of the body. And it evokes a generalized autonomic response like tachycardia, huge secretion of adrenaline, and all those things. In the delivery pain, it is somatic and very fast, because A delta fibers are myelinated fibers. So the transmission is very fast, it is localized, and there will be CVS changes. And that is only not because of autonomic impulses, but because of autotransfusion by the valsalva. When the woman tries to push the baby out, it creates a valsalva, which is very, very important in cardiac diseases. At that time, a huge amount of blood volume comes to the central circulation, can precipitate a heart failure in some subset of patients. So you can stop me, ask me questions in between, because there are a lot of things that I wanted to discuss. So there are a lot of slides. I'm moving forward quickly. Is pain bad in labor? Physiologically, pain is bad in labor because it affects the fetus, mother, and even the uterine contractions. So how does it affect the fetus? Now, everything, whatever happens during pain, all the catecholamines, respiratory rate increases, respiratory rate, it causes vasoconstriction because of hypocapnia, and all sorts of things happen, which ultimately precipitates to fetal acidosis. This is one. Now, if you do a neuraxial, like epidural analgesia, it blunts this, is called the hyperventilation cycle. So between the contractions, when there is no contraction, the respiratory rate that was increased during the contraction, it has driven off most of the CO2, and the hypoventilation happens. So the mother has decreased maternal PaO2. And during contraction, there is increased in the respiratory rate, and there will be maternal alkalosis by driving off the CO2, which shifts the left the oxygen dissociation curve to the left, and the mother doesn't release, mother's hemoglobin doesn't release oxygen. So in both contractions and between contraction, there is always a decreased oxygenation of the fetus. Also, we should anatomically remember that the spiral arterioles that deliver nutrients and oxygen to the fetus, they are deficient in tunica media, or the muscle layer of a normal artery. Because of that, whenever uterine contraction happens, it traverses through the myometrium. That's why the whole of the artery collapses to almost zero patency. So that we have to keep in mind. What happens to mother? The mother can have catecholamine increase with the BP increase and heart rate. These are important for cardiac disease, preeclampsia, those sort of things. Any pain, it decreases gastric emptying time, and because of the specific anatomy of a pregnant stomach, there are increased chances of nausea, vomiting, and it also affects the mother. It is one of the important cause of postpartum depression. So two independent risk factors for postpartum depressions are anemia during pregnancy and improperly treated labor pain. Labor, what happens is, as catecholamines increase, adrenaline is a tocolytic agent. So if the contractions are very sustained and very frequent, because of too much of adrenaline, the uterus doesn't contract properly because of the tocolytic effect of adrenaline. So by decreasing the adrenaline concentration, by doing a neuraxial analgesia, it can improve uterine contractility, and probably it progresses the first stage better. There is no evidence about second stage, but the first stage progression is much better if you have a good neuraxial block. So to sum up, the benefits of the pain relief is better oxygen, better blood flow, better fetal pH. The labor stages progression is better by controlling the amount of adrenaline, and it also prevents birth canal injury. But there are also non-analgesic beneficial effects. Especially in preeclampsia, it can act as an independent vasodilator, epidural anesthesia. In the cardiac disease, it can decrease the preload, so it can blunt the autotransfusion effect, and it prevents postpartum depression. and definitely in obesity, where general anesthesia is risky. If you give a epidural early in labor, it can be used for top-up for cesarean section. So, how severe is the labor pain? So, according to Meljack's pain score, it is quite severe in nulliparous women, like 59%, compared to multip, which are 43%. And the pain is more than cancer pain. And in the pain rating scale, it is called as a amputation of a little finger is equivalent to labor pain. It is quite severe. The nulliparous have more sensory pain during early labor, and multiparous have more pain during the expulsive phase or the delivery phase. That it means the second stage. So, what factors can you think of that might affect pain perception in labor? So, we consider it as a multimodal sort of analgesia. So, you have to deal with the psychological aspect as well by training the mother in the prenatal period, antenatal classes, and all those things. So, it is like mind, body, and iatrogenic. These affect pain perception in labor. So the mental preparation, antenatal classes, which happens in Europe quite a lot, and the religious thing is church in Christian religion. It was considered that medicated pregnancy or pain relief during labor is against Bible. You should have the pain during labor. Uh, Labor analgesia became popular after Queen Victoria had a child, eighth child, Prince Leopold, by having chloroform, which was given by John Snow, which ultimately defeated the church because it was a royal approval. Similarly, what happens during this obstetric period, during pregnancy, if the baby is big, if there are malpositions like occipito-posterior, and other things I will discuss later in later slides. We always, a lot of people in labor ward have the augmented labor by giving syntocinon or oxytocin infusion, and they have more pain. So these things can be addressed by doing classes and all sorts of other, the OP presentation, I will come back later. So pain relief wise, we have non-pharmacological, which has a lot of benefits, and we should pursue that one. But this is beyond the scope of this lectures, because you all people are interested in the regional aspect of it. That's why we are going straight to neuraxial form of pain relief. So this is the gold standard. There are three different types. You can do a one-shot spinal, epidural, CSE, and DPE. So the conventional epidural is considered as a gold standard. I put a question mark. Is it really a gold standard? I personally, I do quite a lot of maternity anesthesia. I was the obstetric anesthesia lead for 6+ years. I don't do conventional epidural. I do CSEs, and this is the reason why. Now, as I told, the sacral analgesia is of most vital importance. The sacral analgesia, the S2, 3, 4 fibers, they are one of the most thickly myelinated nerve. And to achieve a sacral analgesia, it takes around 25 minutes for a conventional epidural. In the Obstetric Anesthesia Association guideline, we quote failure rate during labor is 1 in 10. I don't think this, every 10 mothers gets an epidural, one will fail. That is unacceptable. If you top it up for cesarean section, 5 times more than CSE, it fails. In some centers, they do walking epidural. Walking epidural is not possible with a conventional epidural. It is best done with a CSE. In a fixed cardiac output disease, like aortic stenosis, you cannot do an epidural because it's a high volume thing. We only do CSE with a low dose spinal, and then build it up as to achieve the desired height. Midline identification, it will come in the following slides. It is not guaranteed in a conventional epidural, but with a CSE, it is always guaranteed because you will get the CSF. Getting a CSF means it is a definitive thing that it is in midline. So what can we challenge this conventional epidural with? Is it through CSE or DPE? So if you compare epidural versus a CSE, so the CSE sacral onset time is 2 to 3 minutes. Failure rate is least. And how epidurals work. So when you give 20 mils of epidural drug, percentage goes to block the nerve roots, which carries with it some dural sleeve into the epidural space. So that is one mechanism. The second mechanism is around 20% of this drug diffuses into the CSF for it to work. And the rest of it is absorbed by the local fat and the blood. So this is 3 ways the epidural drugs dissipate. Now, if you do a CSE, it means you have created a hole in the arachnoid membrane. So there is now a conduit from the epidural space to the CSF. So that means you have more of the drugs going by diffusion because you breach the barrier. That gives the quicker onset, and that gives the better intense analgesia. For the walking epidural, what we do is when the mother is in first stage, walking during labor probably helps with the descent of the fetus. That's why a lot of centers who do it, they believe in it. There are not too many evidences, but if you want to do, sound is not clear. I have my AirPod, it's working. Can everyone hear?
Yes, it's sometimes the internet is bad,
Yeah,
but
maybe.
it's
Yeah.
it's okay, I
Oh,
guess.
okay. Yeah. Thank you. So in the walking epidural, what we do in the first stage is we just do a CSE and then just give through the spinal a very low dose of fentanyl, like 15 microgram, and that helps with the complete pain relief, and the women can walk around. There is no motor block. There is no risk of fall. When the intensity of labor pain increases, then we return the mother back to the bed, and then we give the local anesthetic. So walking epidural, the best is to do a CSE. I already mentioned about the fixed cardiac output. So CSE is best for all these things, but I do it for all routine labor anesthesia. What are the side effects of CSE? Now, if you give fentanyl through any intrathecal fentanyl will cause pruritus, it can cause bradycardia, it can cause hypertension. You are introducing something into the CSF, that can be infection and those sort of things. Now, only thing that I circled with red is the bradycardia. So why bradycardia happens? Now, adrenaline is, as I told, it increases quite a lot when you have the labor contractions. So adrenaline is a tocolytic, it relaxes the uterus. Now, that relaxation of the uterus opens up the spiral arterioles for the fetus to receive blood. Now, if you give a very intense and a very quick onset analgesia, the adrenaline level plummets to almost 0, producing a phenomenon called uterine tachysystole, or the uterus goes into a spasm. If it goes into spasm, it squeezes the whole spiral arteriole and the fetus gets no blood supply. And that is one of the most important side effects quoted in literature about CSE. Why it is not done routinely? I do it every day, 11 years. I never had Brady, but there are precautions to be taken. That's why I don't have Brady, but in the literature, there is a incidence of bradycardia. So if you do CSE, you have to know about it. So this fight goes on in the world literature about CSE or epidural, and it will keep on going on. Now, the Americans were a bit clever. They told, okay, because I'm giving some drug through the intrathecal route, that is causing the fetal bradycardia. So we will not give any drug. We will puncture it to make that hole, and then I will give a normal epidural. Then the epidural will, part of the drug will go into the CSF, and that is called intentional dural puncture epidural. So you puncture it, but don't give any drug into the CSF. It is very important that the spinal needle should be 25 gauge. All literatures report those who do with 27 gauge CSE, the hole immediately closes. So you're not getting any benefit of that breaching the diffusion barrier. So only it works with 25G spinal needles. The onset of action is CSE is 2 to 3 minutes and DPE is 7 to 10 minutes. Epidural, as I told, it can take up to 15 to 25 minutes. So what happens with the fetal bradycardia? The incidence of fetal bradycardia quoted in literature is around 3 to 20%. It can be because of a neuraxial hypotension, because I'm giving an intrathecal drug, as I told about the decreased adrenaline. And if I give fentanyl into that, the neuraxial opioid fentanyl side effect is a bradycardia. And we are giving a concurrent oxytocin as a labor augmentation hormone. When you do that, it contracts the uterus more, and now you're adding another effect with the CSE. So most important is if you want to do a CSE, you have to, it's better to do a lateral position epidural. It prevents all the hypotension. You avoid opioids altogether. Just give a little bit of, if you want to, if the mother is not doing a walking epidural, then you can avoid the opiates. Switch off the oxytocin at least 7 to 8 minutes before you start your epidural. Oxytocin receptors are G protein receptors. So the half-life of oxytocin is only 5 minutes. So if you switch it off, all the receptors are empty, and there will be no further augmentation of contraction by the oxytocin. It will be all gone. And then keep your IV fluids and vasopressors ready. If there is a fetal bradycardia, it doesn't mean that the lady will go into category 1 section. So the management is with a mnemonic called SPOILT. You put the syntocin on, immediate switch off the syntocin on. You do a lateral position and give oxygen, IV fluid, and you can use the vasopressors. And if you can't manage it, then you have to do a tocolytic agent like terbutaline, subcutaneous 250 microgram. So that is the management of fetal bradycardia if it happens in labor ward. So I will just quickly go through what are the basics, what are the checklist before labor. So we tell the midwife, it is this one, I prepared it, that there should be IV fluid running, and they have to tell us about the platelets, coagulation. And now most important is the CTG should be normal over the last 20 minutes. If it is not normal, never institute any form of neuraxial pain relief because of the effect of the adrenaline I told. Okay, and then stop scent during neuraxial and restart after 10 to 20 minutes. So next is asepsis. All anesthetists should. It is mandatory in all national guidelines. No epidural and spinal can be done without wearing a mask. There was a Canadian anesthetist who just told, I'm consultant, who are you to question? So the anesthetic assistant told, you're not wearing mask. So he refused. He did 2 sections back to back, and both mothers had meningitis. So there was a very clever microbiologist who, when investigating, asked what happened on that day in theater, and it was revealed that the anesthetist didn't wear mask. the microbiologist called the anesthetist, did a nasal flora, PCR, and there was an exact match of the Streptococcus viridans, which was found in the patient's meningitis sample, and the nasal flora of the anesthetist. So never ever do any neuraxial walk without covering your nose. There was some, this is not, washing hands is always with betadine. In our hospital, some people washed with plain soap. That is wrong. That's why I wrote it that one. And the decontamination of the skin, I don't know what you use. We use a 0.5% chlorhexidine, which is only meant for neuraxial. 2% chlorhexidine is more neurotoxic. But if you use 2% chlorhexidine, then you have to make it completely dry before even you instill the local infiltration in the skin. You cannot spray the back we spray antiseptic. So when we spray, it is like an aerosol. It can precipitate on your open spinal tray. So you cannot spray chlorhexidine with an open neuraxial thing. Next is, what is the update about test dose? Do we do epidural and give a test dose? Most of my trainees say that we test it with lidocaine. And my first question is, why? Several textbooks also say lidocaine test dose. We never use lidocaine in intrathecal anesthesia. So what's the point of testing lidocaine into the intrathecal space? So in modern labor analgesia, there shouldn't be any mention of test dose. Whatever you give, like in a spinal anesthesia, you give around 2 mils of 0.5% hyperbaric bupivacaine. That means you are giving 10 milligram. So if you give 10 milligram of bupivacaine diluted in your epidural, that should be your best test dose. If it goes into intrathecal, you will have hypotension, you will have a little bit of motor block. So what we use is 10 mils of 0.1% to 15 mils of 0.1%. And that is one dose you give it in a way that you give 7 mils first. I have made one dilution. This is one of the protocol that we use. 7 mils, give a 5 minutes break, then give a 7 mils, 5-minute break, and then give the rest 6. So you can give 20 mils over a period of 10 minutes. So that is the best test dose. There is no role of any other things like adrenaline or lidocaine. Chlorprocaine has been used in US. It is the only country which has 3% chlorprocaine. Just to test that if you have given it, it will immediately within 3 minutes produce hypotension and motor block. But the problem with chlorprocaine is it adversely affects the efficacy of bupivacaine that you will be giving later on. So I won't advocate giving chlorprocaine at all. And fentanyl has been used for intravascular test dose. If you give fentanyl in an epidural, 50 to 100 mics, it goes to vessel and patient will feel drowsy and asleep. But I don't think these are valid nowadays. Only test dose is to give 10 mils of 0.1%, or you can maintain what protocol we do like that. So I always encourage everyone to do ultrasound of the spine before doing it, because in laboring mothers, because of pregnancy, there is lumbar lordosis. Whatever you feel with your fingers, the Taffier's line, whatever you feel, it is always 1 to 2 space higher. If you do ultrasound, you will realize that everyone punctures at L23 or L12 even. So doing ultrasound, it takes only 2 minutes and you can mark it. We use NRFIT system, which is the new European guideline, but most countries still didn't move on to NRFIT system. Always use, there are different types of epidural catheters. Always use the multi-hole. There are 3 holes epidural catheters most of the time. And it helps with a very good spread, or it is called epidural spray. If you use a single orifice catheter, most of the drug, it precipitates to your cauda equina. It doesn't spread. For the first stage of labor, you need at least T10 spread. So using a multi-orifice catheter, it is better. So after the procedure, you have to give the midwife or whoever is looking after the mother that you have to do the blood pressure and all those things. The most important thing people forget is to measure the temperature. Why? I will come to it later. And the next one is always check the pressure areas, because if the mother is sitting like that for long labor, there can be, it has been reported, pressure source also. So I will click on this one. I will bypass this slide. So we have a case now. There is a 33-year-old lady. This is the third baby. Had an epidural sighted 3 hours ago, was working well, now experiencing intense pain. What more do you need to know, and what are the options? Do anyone want to do interactive? What is happening here? Okay, I will move on. So this is sort of a breakthrough pain. You always rule out that the catheter is not kinked, the epidural pump we use is working and all those things. But most important is the obstetric cause is uterine rupture. Yes, stage has progressed, Sobia. That is also right, that the mother is multiple. So the baby has come down into the perineum quite fast. So quick progression of labor can cause this breakthrough pain. Full bladder is one of the most important cause, because full bladder adds on to the visceral pain or an existing. So yes, this is most important thing is the sinister thing is uterine rupture or abruption. So you rule out all the epidural catheter problems and everything. The moment you go into a room where epidural was working and now not working, patient in pain, always look into the CTG. If you don't know how to look at the CTG, call the obstetrician. The first thing you have to rule out, is there any uterine rupture or abruption? You can save the mother and the baby. Rest of them, you have ample time to look into it. It can migrate and it can do anything, but rule out uterine rupture and abruption. Okay. So next question is, this one also is interactive. So you ruled out everything, no abruption. So now you think that the mother needs a little bit extra help, as Sobia was mentioning, that the labor has progressed too fast. Baby is now into the second stage, sacral segment. So now you want to give an extra top-up of local anesthetic. So 10 mils of 0.25 or 20 mils of 0.125. Who will win amongst these two anesthetists? Any idea? Okay, any idea? So I got one answer. Yeah, all of you have written 20 mils. In UK, wherever I ask this question, everyone says the 10 mils one. All of you are right. So it's the volume that will win and not the percentage. Again, Fick's law of diffusion, there will be more volume in the epidural space, there will be more transfer to the CSF by concentration gradient. But the whole aim of this bolusing to rectify your inadequate analgesia is at the end of the whole labor, there should be least motor block, because the mother has to push. You need the muscle power to push the baby out. The lowest amount of LA consumption is the best. And the one pump, if you do like this, bolusing, it should have a longer duration of action. So this debate, volume or concentration, is it was found that analgesia was longest in the 20 mil group. And if you, I will introduce two terms which are like MLAV and MLAD. So MLAV is minimum local anesthetic volume, and MLAD is minimum local anesthetic dose. Every block regional anesthesia you do, before doing that block, you have to know the MLAV of all those blocks. Like medial infraclavicular, which is popularly called as a costoclavicular block for the brachial plexus. It has a MLAV of 25 mils. So if you do that block with 15 mils, it's not going to work. It's an insufficient. Similarly, for an interscalene block, there are different ranges like 10 to 15 mils. You have to use at least that volume. Otherwise, the interscalene is not going to work. So every thing has a MLAV and MLAD. So for 0.125%, it has been calculated as MLAV of 13.6 mils. So that is your minimum volume. And the MLAD is only coming to total local anesthetic is much lesser, 6 milligram lesser than your 0.25. So at the end of the day, you shouldn't give 0.25 because overall local anesthetic consumption should be lowest in labor analgesia. So similarly, which one will have the best duration? 0.5% 4 mils, 0.2% 10 mils, or 0.1% 20 mils. Again, this one also the volume will win. It will produce the longest duration. MLAV is 13.6 regardless of patient's body weight, nothing. These are pharmacokinetic variants which has been calculated by experimental chemistry. So what I'm telling is if you go to the MLAV one, 13.6 mils, suppose you have a bigger patient, you can add 15 mils. But what I'm telling, compare with this two doses, the comparative doses of MLAV of 0.25 and 0.125, the total local anesthetic that is going inside your body is always higher when you use 0.25. The whole purpose of labor analgesia is to use the least amount of local anesthetic to produce analgesia. That's why always use diluted concentration and not the concentrated solutions. Happy? So till now, epidural summary is a good thing. It is good for fetus, good for mother, good for labor. The bad thing, yes, we do accidental dural puncture. We can produce local anesthetic toxicity. There can be patchiness and some bizarre type of blocks can happen like the subdural block. So subdural space is a very ill-defined space which ends in the midbrain. Epidural finishes at foramen magnum. The subdural goes to midbrain. So if a patient has a subdural and you top it up inadvertently for cesarean section, it can produce neuro manifestations. The patient can have some bizarre sort of neuronal event happening in the cerebrum. Then comes your, it will never work properly. Subdural produces very patchy block. There will be complete block of the chest, but there will be a complete lack of block in the sacral area. So these sort of aberrations can happen. And the ugly part of the epidural is if you have done a dural puncture, total spinal and sort of things. Any questions till now? So the myths and controversies, does it increase the rate of operative on instrumental deliveries? Is epidural the cause? It never increases the rate of cesarean section, but it prolongs the second stage by 1 hour in multip and 2 hours in primate. So it can increase the rate of instrumental deliveries. But with the modern use of 0.1% or less, bupivacaine, the incidence of CS and instrumental is probably decreasing and it's probably normal, like a non-epidural labor. Then another problem that happens is the epidural fever. It can happen in 11 to 33%. It's called epidural-related maternal fever. What happens is we don't know what happens. There are cellular dysfunction like mitochondrial dysfunction, uncoupling of oxidative phosphorylation by the local anesthetic. Local anesthetic, remember, it goes inside the cell and disrupts the mitochondrial metabolism, and that is one of the mechanism how intralipid reverses the toxicity of local anesthetic is by going around that mitochondrial channel. It is beyond the scope of this lecture, but these are the reason why heart only needs lipid for its metabolism. The fuel of heart is fat. The fuel for brain is glucose. So that's why when there is a cardiac arrest from local anesthetic toxicity, if you give 20% lipid, like intralipid, it gives the fuel to the heart to again bring itself back to life. And these are all through the mitochondrial problem. There are different alarmins and inflammasomes, which a lot of researches are going on, which are released that are mediated by local anesthetic induced tissue damage. It always happens if the epidural is in place greater than 5 hours, which is very common with the primate population. Then the primate who request epidural at 2 centimeters, that is very early labor, they probably have a background of chorioamnionitis, which a lot of researches are going on why some mothers request epidural right from the beginning and some mother request it at 6 centimeters dilatation. The only problem with this epidural fever is the neonate which is delivered, because mother had a fever, the neonate has to go through all sets of blood investigations to rule out neonatal sepsis. And if the fever persists, there are incidences of increase in the neonatal encephalopathy. So temperature management and temperature monitoring after epidural is mandatory for all epidural in labor. This is, I've discussed, and there is no problem with breastfeeding. It doesn't come. So we have finished up to that, the neuraxial analgesia for labor. And during the removal period, you have to rule out these things. That if you have done an epidural for a preeclampsia, you need a recent platelets before removal. Otherwise, there will be hematoma. Major obstetric hemorrhage beyond 2 liters. You always need a coagulation screen and platelet before you remove the epidural. And if in doubt, just ask for help. The newer forms of labor analgesia, these are pharmacological, it's not the scope of this lecture, is remifentanil. And you shouldn't stop drinking even if you have a section. This is called sip till send. So the mother and the baby stays healthier. So they should drink pure water, plain water. There is no restriction and you shouldn't stop it. It should be, but there is a guideline like 250 mils in an hour. So if you are waiting for the cesarean section, you have come to hospital at 9 o'clock, you have seen the mother, the section is at 2 o'clock, they should drink all throughout up to 2 o'clock. I allow them to even bring their water bottle into the theater complex. So we discussed about it. If you have PDPH, what are the non-blood patch techniques that are there? We all know about the greater occipital nerve block, but there is a new block which is called the sphenopalatine block. I have done 20 in my hospital, 16 didn't need a blood patch. But it is not still there in the guideline or any prospect recommendation, but it is worth doing it. It is a very good block where the mother is refusing another epidural for blood patch. Next, I will come to the post-operative thing. We monitor these patients for PDPH. I won't go into PDPH today. The neurodeficit, weakness, and all sorts of other things. So the neurodeficit that happens from an if you have an epidural and the mother has some neurodeficit, you have to go and see. The most important cause is obstetric cause. The size of the fetus or malposition, fetal head. These are called compressive neuropathies, which are almost always obstetric. Having a compressive neurodeficit from our side, it can be caused by hematoma and epidural or spinal hematoma and epidural abscess. But other thing is the ischemic thing. If there is a prolonged hypotension during any phase, that can cause ischemic neuropathy, which is, you have to remember about it. If it's a very big baby and a very prolonged labor, the baby's head can compress on the internal iliac artery, and that can also cause ischemic neurodeficit. So this is some of the recent things that has been added. That's why I put it. So how do you assess a neurodeficit? So you go and see the mother, that the mother has weakness in the legs. So what will you examine the mother? So the most important examination is first his history. If a mother has back pain, then you touch with a cotton ball. The touch sensation, if it's absent in your posterior rami distribution, all of the front of your body, your neck, your arm is brachial plexus. By definition, it is the ventral rami of C5 to T1. Neck, cervical plexus, C1 to C4. Chest, intercostal. These are all ventral ramus. When a spinal nerve comes out of the spinal cord, it immediately divides into ventral and dorsal rami. The dorsal rami supplies your spinous processes and the vertebra and the erector spinae, the paravertebral muscle. So if you touch on the spinous area and there is no sensation, that means this is a central cord syndrome. You have to immediately do an MRI. After that, you will ask about the central cord syndrome, incontinence, and all those things. But just by doing one examination, by touching the posterior rami distribution, you can prevent a sinister thing happening. If there is a vertebral hematoma or a vertebral or epidural abscess, you only have 6 hours, max 12 hours to save the mother from paraplegia or permanent damage. You have to divide a neurodeficit into, is it a radiculopathy, which is a central syndrome, which can be a hematoma, which can be an abscess, which can be just a cauda equina syndrome. Just beside your spinal vertebra is your psoas muscle, where there is lumbosacral plexus. So it can be plexopathy. In a plexopathy, lumbar plexus has different branches: femoral nerve, obturator nerve, lateral cutaneous nerve. So you will have a neurodeficit in at least 2 nerves in a plexopathy, which you just tell them, prevent fall, tell them, reassure them that it will go off in 6 weeks to max 6 months. The mononeuropathies are always because of the obstetric causes, the fetal head or lithotomy position for instrumentals. Those sort of things causes mononeuropathy. So you have to rule out by examination that is it a central or a plexopathy or a mononeuropathy. MRI is mandatory if it is radiculopathy, where pain starts, there will be back pain, it will radiate to your legs, and there will be sphincteric incontinence. And as I told you, the posterior ramus, lack of sensation and lack of perineal or the sacral area sensation. That is very, very important. Is EMG important? I always say that as anesthetists, we are prone to litigation. I don't know about Bangladesh, but in Europe and everywhere, obstetric anesthetists get a lot of litigations, complaints and all those. Any neurodeficit, it will come as a complaint against you. So EMG is very, very important, that EMG can rule out peripheral to central. So EMG only gives a diagnosis of all these plexopathies and mononeuropathies, which are not our epidural or spinal things. So epidural spinal can only cause radiculopathies, but the plexopathies and mononeuropathies are all because of the obstetric causes. That's why EMG is important. But remember, EMG, you have to do it in the first day or second day. But EMG abnormality will only reveal after 3 weeks. So why do we do it in 2 days? Because of the baseline. Was there a preoperative neurodeficit? EMG at 2 days will reveal any preoperative neurodeficit, and 3 weeks EMG takes time. The neuromesis and all those nerve damages, it takes time to reveal in EMG. So you have to repeat the EMG at 3 weeks to say that this is caused by this delivery or this labor. Then you have to inform the mother about fall prevention and temperature management. So if there is an insensate limb, it can cause burns and blisters if they use hot water bag and all sorts of things. So that was the labor anesthesia update and little bit of anatomy update. So we all talk about the Bateson's plexus, the venous system, that it is always in the anterior epidural space. So if you have a traumatic or a bloody epidural, it is not puncturing the Bateson's plexus. That is a wrong concept. At the lumbar level, there are no posterior veins, or if there are posterior veins, they are all rudimentary. Epidural veins are valveless. That means if you sit, the gravitational effect, all the blood will be more pulled towards the lumbar area. So sitting position can cause more bloody catheter. I'm talking about epidural because epidural, it can deviate from the midline because you're just doing it blindly. Epidural arteries are in the lateral epidural space. If the anterior epidural space, there are septate fat layers. So if the epidural, you have to be in the midline to avoid bloods. So ultrasound is the best, and the combined spinal epidural is the best, that you are 100% in the midline, number one. If you thread the catheter beyond 5 centimeters, we did one last week, 160 kilo patient. It was a one-shot CSE we did, but with a very long needle. The only thing was we threaded it to 6 centimeters because there are 2 centimeters when you lie the patient back, there can be 2 centimeters outside migration. So only in severely obese or morbid obese, you can put it 6 centimeter, but normal population never put beyond 5 centimeter. What it will happen? It can go anteriorly where there are septate fatty layer where the epidural will never spread properly. Or it can go to the lateral side and it will become patchy and unilateral. Then comes what sort of epidural thing that you will do. Will you do a midline or will you go a little bit para? So any idea before I go into do you want to do a midline epidural? Which one is better? Or a paraspinous? Paramedian term should be abandoned in recent time. Paramedian has no meaning nowadays. Do you know why para? Para is the best. No one should be encouraged to do the midline. What we do normally, no one should be encouraged to do spinals and epidurals midline. Any idea before I go to the next slide? So I'm just waiting for one more answer. I'm just having a flavor piercing. What do you mean by that? So para is a paraspinous. Now, when you go through the midline, what you do is you go through the supraspinous ligament, interspinous ligament, then you puncture the ligamentum flavum and then enter your epidural space. So one concept is ligamentum flavum is an interlaminar ligament. So ligamentum flavum is a right flavum and no. Para has to use flavum. I'm telling you. So para, there is one ligamentum flavum on the left side, one ligamentum flavum on the right side. They come in the middle to crisscross. And that's how in the midline, you get the ligamentum flavum, the crisscrossed ligamentum flavum from both sides. Now, the problem is anatomically, 5% of human being doesn't have a crisscrossed ligamentum flavum. That means you are going through supraspinous, interspinous, and then there is no ligamentum flavum, and you go straight. That's why dural punctures happen. So always try to do it paraspinous, which is paraspinous by definition is 0.5 centimeter to 1 centimeter away from your midline. So palpate the spinous process, just go 0.5 to 1 centimeter. In older textbooks, or how we learned, was paramedian, which was 2 centimeters. Never go 2 centimeters. Only 0.5 centimeters away. What will you penetrate? Skin, subcutaneous tissue, paraspinous muscles, followed by ligamentum flavum. Ligamentum flavum is always there on the side. Ligamentum flavum may not be there in the midline. So that is one, is called paraspinous advantage. Now we always say if there is a backache, no. Epidural doesn't cause backache. You have progesterone, which relaxed your ligament. During pregnancy, you have lumbar lordosis, you stretched your ligament. That's why you're having back pain. Does epidural cause back pain? Yes. Puncturing supraspinous ligament causes backache. So by doing a paraspinous method, you don't increase the chances of backache. Second advancement. Third, by doing a paraspinous, you have a lateromedial angulation, very less, only 5 to 10 degree, not more. If you do that angulation, what you are doing is you are puncturing the paraspinous muscle in one angle. Then you puncture the ligamentum flavum at a different angle. Then you suppose you have done a inadvertent dural puncture with your epidural needle. So you keep on going to the CSF. That means you have punctured the arachnoid membrane at a different angle. Because all those holes that you have created are at different angles, when you take out the needle, these acts as a flap valve, or they closes upon itself, reducing the incidence of dural puncture, even if you have done an inadvertent dural puncture. So that is called the flap valve, and the PDPH incidence decreases. At the end of this slide, can you see the last question? In ankylosing spondylitis, in severe arthritis, theoretically it looks cool, but evidently I couldn't read the rest of it. So I have stopped doing midlines at all. It is very easy, and it is one of the easiest procedure. And if you do it, then you will never revert back to the midline. So this is very important, that in osteoarthritic spine and in ankylosing spondylitis spine, can you do midline? You can't. It is impossible to do it. But which space never narrows in those sort of condition is L5S1. L5S1 it always stays patent, whatever arthritis happens. Okay. Next is, can anyone tell me why loss of resistance happens in lumbar epidural? Any answer why loss of resistance happens? So your endpoint of epidural is loss of resistance to saline, or if anyone uses air nowadays, it's loss of resistance. Why loss of resistance happens? Enter into a potential, okay. So sorry for the paraspinous thing. AR has written theoretical, it looks cool, but evidence is poor. No, you should read the 2024-25. There are several articles. These are new concepts. This lecture is about update. So I'm trying to update you. I'm also like doing 30 years of anesthetic. Midline has higher success rate. It's all rubbish what you are talking. I'm sorry for the word. Read the British Journal and all the recent articles over the last 2 years. This lecture is about, I'm just updating you. You take it or you don't take it, it's up to you. Negative pressure. There is no negative pressure in epidural space. Negative pressure is there in upper thoracic and cervical epidural space because of intrapleural negativity. There is no negative pressure transmission from intrapleural space to lumbar epidural space. epidural space is a potential space. No, it is full of fat and nerve fibers and blood vessels and everything. So yes, AM has written something which triggered my interest. As I told you, the ligamentum flavum from both sides, it crisscrosses, and it is an elastic ligament. So when it crisscrosses, it becomes a very tough ligament. When you are using a 16 gauge or 18 gauge big epidural needle, what you are doing is you are tenting, as you push, you are tenting the ligamentum flavum. As you tent it, you will feel a gritty sensation all the time. So the moment you puncture that ligamentum flavum, the ligamentum flavum, because of high elastic content, it springs back, producing an artificial vacuum. So that's why you have to be pushing the ligamentum flavum quite a lot, because it is very tough in the midline when it crisscrosses together. So ligamentum flavum is a very, very strong elastic ligament, which you do tenting, and then it springs back, producing the loss of resistance. The next question is where the conus ends. Conus is L1, but there are 15% population, it ends at L3. So be very cautious. That's why going lower spaces is much better, and always do an ultrasound. Lumbar lordosis changes the palpated level in pregnant women. If you feel that it is L3-4, it is always L2-3. So be cautious in pregnant patient when they have lumbar lordosis. So the physiology, a little bit of pharmacology update. I think I still have 20 minutes, no? 15-20 minutes? Dr. Ajit, I think...
Yes. No problem, go on. Yes.
Yes, so why spinal hypertension happens? Whenever you do a spinal in a cesarean section, hypertension happens. Why it happens? So one is normal. There is the vasoplasia in your peripheral thing. You can write comments. Yes, I've seen one T1 to T4 block, sympathetic blockade, vasodilatation, peripheral vasodilatation. Yeah, so basically it produces peripheral vasodilatation, producing baroreceptor reflex, tachycardia. That is basic. From medical school, we know. What are the most important causes of hypotension with Brady? The hypertension with Brady is because of the cardioaccelerator fiber T1 to T4. That one also we know for last 20-25 years. So what you have to know special, there are special left ventricular receptors, which are very, very rich in serotonergic receptors, 5-HT3 receptors. These receptors are triggered. This is called an empty heart syndrome, where the blood, if it is not coming because of the decrease in the preload, these receptors gets activated. Maybe it is a physiological advantage that whenever you have an empty heart, because you are not drinking that much, you have now, we don't do preloading nowadays, all are co-loading. Your heart is already empty, and then you produce a peripheral vasodilatation. So blood is not coming to your, very good. So AR has written the Bajol-Jarisch reflex. So this left ventricular receptors triggers a reflex called a Bajol-Jarisch reflex. So when you have less blood in your left ventricle, it goes into a bradycardia to make the diastolic time more, so that the Frank-Starling mechanism works better in the next cardiac output. So that's the reason these are very rich in serotonergic receptors. Giving ondansetron before doing a spinal anesthetic can prevent some of the Bajol-Jarisch reflex. Remember, any sympathetic block you do in two conditions. One is spinal anesthesia, and the other one is shoulder surgery with an interscalene block in sitting position, also triggers Bajol-Jarisch reflex, because interscalene block, basically, it always percolates into your stellate ganglion because they are very close to each other. So you will have Bajol-Jarisch with a significant hypotension with Brady in shoulder anesthesia as well. So that, you remember the Bajol-Jarisch, that is a very important thing. Then comes 1780s, there was a a scientist who wrote about this Bainbridge reflex. The Bainbridge reflex is if you instill sodium chloride into right atrium, tachycardia happens. If you don't give any sort of fluid into the right atrium, it goes into bradycardia. A new term has been coined. I don't know the veracity of it. A lot of textbook has written. That's why I'm mentioning reverse Bainbridge reflex also causes bradycardia with hypotension. And obviously, supine hypertension in a pregnant mother having section. Treatment, lot of papers are coming now that noradrenaline is the best because phenylephrine was considered as the drug of choice to treat hypertension, but phenylephrine causes significant bradycardia. So those drugs which have an alpha agonist along with a little bit of beta 1 effect, it maintains the hemodynamics much, much better. So phenylephrine was considered as a drug of choice, but if you read the international consensus statement of using vasopressors after spinal anesthesia, a lot of things have gone into noradrenaline. So I haven't used it personally, but it can be used peripherally for short cases like a cesarean section. Then you have to use a lesser amount of hyperbaric bupivacaine. So how much is your normal? Can you give me the answer? How much hyperbaric bupivacaine do you use for your section? How many mils of 0.5% do you use? Yeah, metronidazole is also very good because it has a little bit of beta 1 effect. Thank you, Mahmood. So 0.5%, yeah, 2.2 to 2.5 mils, 12.5 milligrams. Sylvia has written 2.5 milligrams. So is there, you are all writing something 2.5 in Coventry University, Coventry Hospital, Tertiary Obstetric Center. They use 3 mils. I use 2.2 mils. And I grew up doing my master degree and everything in India. Professors used to scold us if you ever use greater than 2 mils. Is there any guideline? Why are you using different people use different thing? So ED95 of hyperbaric bupivacaine is 11, in some books written 11.3 milligram. That means you will get a proper block in 95% of population by giving 11.3. So it is better to give 12 milligram. I think that is better. Some of the Oxford textbook of obstetric anesthesia, the editor writes that he uses 8 milligram. But the incidence of intraoperative pain during section with 8 milligram is too high. So there is no point using 8 milligram, which is called the low dose final. So I think 12 milligram is ideal, but a lot of tertiary centers, because of litigation problem, they use 15 milligram and then use huge amount of phenylephrine just to counter the hypotension. Always use adjuncts, definitely. Opioids is most important. Next is, you did a beautiful spinal anesthesia, 1 attempt, CSF came out. You inject the drug 20 minutes after, there is no block at all. So definition of spinal failure is you have to wait 15 to 20 minutes after a successful CSF you have injected into CSF. And why this happened? Any idea? You have given a beautiful spinal. So yes, the needle position was not good. Drug error, very, very important. Yes, I mean, you have done a very good spinal. So drugs and everything you have done. Very good. Nysora reference. Yes, Nysora is discussed in detail about some of the things that are very good. But in recent articles also, there are some more thing. Protein binding doesn't affect. There is protein binding is it's a much more later thing. It has to be in the CSF. It doesn't get absorbed into bloodstream. There is no protein in CSF as such. Yeah, storage of drug. Yeah, so those sort of problems. So I will just come to the. So, is there any effect of speed of injection? Who does slow and who does fast? Yes, Scorpion bite. That is funny. That happened actually. Yeah. Midway. So, do you know what is the rate? Any article ever said that what should be the rate of injection? Barpotage it has no role in modern. So speed of injection, slow or fast. In literature, only one literature available that says 0.5 mils per second. So whatever your volume is, you have to, if you have a 2 mils total volume, you have to give it in 2 seconds. So it has to be 0.5. It has to be faster. There is a reason for that. Why? So all of your needles are, do you use Quinky or Whitaker Sprott? What do you use normally in your day-to-day life? Yeah, 0.5 mil per second. Very good, yeah. Quinky. Is Arif writing Quinky? We never use Quinky. If Arif is from UK, in UK, we never use Quinky. Pencil point Quinky, Sobia. Pencil point Quinky. So Quinky is a cutting needle. So cutting needles are never used nowadays in modern anesthesia because it produces a U-hole, a bigger hole, where I will come to it in a bit. We always use the pencil point. The pencil point is there is no hole at the distal end. It has a lateral eye. So the eye, size of the eye is quite large. So if a part of the eye goes into CSF, subarachnoid, the part stays in outside the arachnoid, in the epidural space. So because of capillary action, CSF will come out. But when you inject it, all the injection will go into the epidural, nothing will go to the spinal. If you inject it at a proper rate, which is a little faster than what normally people do, what I have seen, all the drug comes from the most distal orifice. So the orifice is divided by the dura, or by the eye of the needle. Pencil point has both Sprott and the Whitaker. Half of it goes inside, half stays outside. So I will tell you over the solution. Always use hyperbaric because that has the most predictable spread for cesarean. Hyperbaric has no role in hyperbaric has only role for joint arthroplasties in the lower limb. Other than that, hyperbaric has the most better spread and the predictable spread. How can you make the low dose spinal work better? I'm coming to the solution. Speed of injection, preventing spinal failure, is 0.5 mils per second. After finishing the injection, I've seen most people immediately, swiftly withdraw the needle. Never do that. Always count up to, I count up to 10. This 10 is my number, but always hold it a little bit. The moment you inject it under pressure, that amount of drug that goes into the CSF, you swiftly remove it. It is a 25G needle. Drug leakage happens outside into the epidural space. So you're losing the drug from the CSF. So always hold the needle inside the subarachnoid space. Just count up to 5 to 10, and then you take out slowly. Then if you use a Quinky needle, which is a cutting needle, it produces a U-cut. And the U-cut, it's called the tin lid phenomenon. That means when you create that hole, the hole never closes. So that hole then leaks from the CSF into the epidural space. So Quinky shouldn't be used in modern day spinal anesthesia. So in Europe, we never use any Quinky at all. All Quinkys has gone. It is only Whitaker or Sprott. Then someone mentioned, I was very impressed, that cyst in spinal, 4.5 to 9% chances. It's a Tarlov cyst. Tarlov cyst, it is a cyst which contains fluid. So you puncture that cyst, you get CSF, then you give drug, nothing happens. So that is incidence I have given you. If you have done an epidural top-up and it didn't work, and you want to do another spinal in the same space, sometimes you get that epidural top of fluid coming like looking like CSF. So you can always do a dextrose test and check that whether it is a CSF. Next is, if you use low dose spinal, how can you make it effective to go up to T4? That is your minimum requirement for cesarean section. Always use two methods. Trendelenburg or gravity alone is not a very good solution. Flexing the knee, flexing the hip, it removes the lumbar lordosis. That spreads the local anesthetic much more higher. So using gravity like Trendelenburg and flexing, using the curve of spine to rectify the lordosis, especially during pregnancy, cesarean section, it spreads the local anesthetic much higher than you anticipate. So that's why always do that maneuver whenever you do a low dose spinal in a cesarean section. Then comes whether half of it is outside the eye of the pencil point or half inside. You always, when you get the CSF, you always use 90-degree Alicort's rotation, that all four quadrants, the CSF is flowing. Then you can remove all the dura. If it is half, it won't come in some places. So always do a 360-degree to eliminate any dural catch. If it's half outside, you won't get it, the CSF back in when you rotate. So that was the end of my lecture. Thank you. And I will take questions. It was a bit long slides because so many updates has come into this one. Hope you enjoyed it.
Wow. Thank you very much. It was wonderful. And I guess all the people who heard your lecture must be mesmerized by the new information and addition to their knowledge. So, yes, it was thoroughly enjoyable. And
Thank you.
Thank you very much, Dr. Dasgupta. And this floor is open for any questions and any comments. You can ask questions or put it in the chat box.
And I'm one of the neuraxial question setter for a lot of regional anesthesia exam worldwide. And yes, so a lot of whatever I gave a talk, it was good. I did it in Europe as well. Some of the newer aspects of neuraxial. So yeah, hope, I mean, when you practice it from tomorrow, you reflect it in your practice. You will enjoy it. I mean, there are so many new things which has come. But most of our trainees, we have two students from Bangladesh. They have gone into the next update, so that's good. Yes, I use needle to through needle for CSE. It is, but not the. I use a normal epidural needle. Suppose 8 centimeters, and then I use a 120 length needle. So needle through needle. The thing that has Braun has one which clicks. It is a pre-made CSE needle. You can use it, but it is costly, so they don't want to buy it. So you can just do a 25G spinal needle through an epidural needle. But the spinal needle size should be 120. It should be 4 centimeters more than your spinal needle, at least 4 centimeters more. Yeah, Israt, I definitely, I will try to do some regional anesthesia talk, and it will be all problem-based learning. So if you like this sort of preparation, because labor anesthesia, there are 1,000 videos in YouTube, the talks. That's why I wanted to do practical and problem-based. The causes of bradycardia after spinal anesthesia is of 3 types. All are about reflexes. So one is cardioaccelerator fiber blockage. If you have a block above T4, remember sympathetic block is always 2 segments above your sensory block. So if you have a sensory block at T4, that means it is T2 already blocked for the spinal, number 1. Number 2, there is activation of left ventricular receptors in the left ventricle, which are rich in serotonin. That is Bajol-Jarisch reflex. There is a parasympathetic hyperactivity. Bajol-Jarisch reflex actually came into picture mostly it is always in the inferolateral wall of the myocardium in the left ventricle. That's why all inferior wall ischemic patient or MIs will always have a brady with hypotension. So all inferior wall MIs have Bajol-Jarisch reflex. So that is one. And because preload is not coming to the right atrium, the heart goes into brady because of a reverse Bainbridge reflex. The reverse Bainbridge existence we don't know, but if you read most of the textbooks or current anesthesia exam preparation books, all of them write it because someone has popularized it, but we don't know existence. Bajol-Jarisch has an existence.
Correct. Now, just to have a discussion, you said that you're using 0.125 of bupivacaine for the continuous analgesia and epidural. Where in my center, I usually use 0.0625 in a larger volume, as volume is, as you correctly said, volume is most important. So in that case, if I use, I've seen that if I use 0.0625, I can play with the volume much more easily than using 125. Yes.
Yeah, you are right, because most of the literature says it is better to use 0.0625. But in UK, what happens is we get a premix bag of 0.1 plus 2 microgram per mil of fentanyl. So because it's a premix bag, we just connect it. But literature says your technique is the best. But in UK, we don't have any 0.0625, but that is the best percentage, because volume always wins.
Yes.
Not the percentage, yeah.
In that sense, we are lucky because we only have 0.5, so we have to make our own.
Yeah, that's very good. That's very good. Yeah.
So that is one thing. And regarding the NR-fit syringes, we don't have that. So
yeah, I mean that is costly. That is a
yes.
Yeah, that is costly. But there were some one midwife accidentally, or a recovery nurse in UK accidentally connected the epidural into IV. That's why we have changed everything to NR-fits are all yellow. You cannot do, even when you are asleep at night and they call you for an epidural, you cannot connect it to IV because the holes are smaller and completely different.
Right. Absolutely.
And who are the ideal Xiaomi? Who are the ideal patients for this procedure? Means, are you asking for CSE, or who are the ideal patients for what procedure? There is one question in the chat box.
Who are ideal patients for this procedure, sir? Ideal patients mean the
for
CSE.
CSE, yes. So CSE, if you come to my hospital, I do only CSE. And I told you all the advantages of CSE. We did an epidural failure audit. In UK, we quote 1 in 10. It's not all are done by Dr. Ajiz. I mean, we are senior people. Our epidural anyway works better. But if you want the epidural not to fail, 1 in 10 failure, that is a huge in UK. When we did it in our hospital audit for 6 months, it was 1 in 6 failure. Then we went into each and every individual operator who is failing. And then CSE never failed. So I only do CSE. So then all trainees on my day only do CSEs. And CSE never fails because of the reasons I gave it in the lecture. But if you want to have the indication, number one indication is occipito-posterior position. In an OP position, low back pain triggering the sacral fibers, it's so big that epidural at a low concentration is very, very difficult to penetrate the myelin sheath and block it. Sacral analgesia is a very, very important component for OP position. So if you have an OP, I keep a very low threshold on CSE. Otherwise, epidural works, but it may not work. Then comes your, there are certain subset of population. It doesn't happen in Bangladesh, but in here, there is quite a huge number of teenage pregnancy. So they just become pregnant. There are a lot of benefits to become pregnant in this country, monetary benefits. That's why they just become pregnant. They don't have any idea, no knowledge, never come to antenatal classes. They mostly smoke. It's not derogatory. That is a true thing because I do with passion obstetric anesthesia. What they feel is when the labor starts, they just want to push the baby out and then go for a fag. In doing so, the cervix is still not effaced properly. So you are now bumping the head of the baby in a closed cervix repeatedly by involuntary pushing. The cervix gets inflamed and will never dilate. Unnecessarily, this young girl will undergo a cesarean section. So to prevent involuntary pushing, they don't listen. The contraction comes immediately, they will push. Really, really proper Valsalva pushing. To prevent this is called involuntary contraction. So to prevent this, you take out the pain completely. CAC can prevent sections in those subset of patients who don't listen and just keep on doing involuntary contraction. I do CACs for obese patients because it can act as an introducer for the, because the CAC helps you get the midline, because obese patients very difficult to palpate midline. So getting a midline is very important. If you get CSF, you are 100% in the midline. In a parturient with preeclampsia, sorry, yeah?
No, the previous question, do you still use intrathecal morphine in UK nowadays?
No, during COVID, all diamorphine comes from Germany. During the Brexit time, there was no supply of diamorphine. Then we used for, I think, 6 months morphine. It's a very interesting question. Unless and until, because it's nighttime in Bangladesh, if you're not feeling sleepy, if you use morphine, most important thing is you have to use fentanyl. Because morphine's onset of action intrathecal is 20 minutes. Number one. Number two, morphine will, you know why itchiness from morphine happens only in the face and upper chest and upper back? Because the spinal nucleus of trigeminal nerve, this is all trigeminal nerve supply, it descends into the spinal cord up to C2 level. So when the morphine floats, it takes 20 minutes for it to trigger those trigeminal spinal nucleus. These nucleus are rich in serotonergic receptors. So again, if you give ondansetron 20 minutes before the intrathecal morphine, it can prevent itchiness. So there are a lot of articles about it. Yeah, yes, morphine, we use it, but I use diamorphine and I also use some quadratus lumborum block for cesarean sections because diamorphine effectiveness is 6 to 12 hours. Yes, yeah, Ms. Scorpion Bite, that article I have seen it, SPM. Thank you very much. You wrote it before. It was very funny. Okay.
There's another question here. In a parturient with preeclampsia, how does the choice between low-dose epidural analgesia and combined spinal epidural impact hemodynamic stability?
In preeclampsia, there is never ever any hypotension with a spinal, because this is an imbalance of your angiotensin and endothelin, which are the strongest vasoconstrictors. So they are so abundant in a parturient with preeclampsia. How many of you answered it in cesarean section? Give a normal dose. How many of you ever given any vasopressor? I have never given in a proper preeclampsia. Preeclampsia never causes spinal hypertension because of the severe imbalances between the endothelin, which is your strongest vasoconstrictor in your body, and angiotensin 2. There are no vasodilators. All are vasoconstrictors all around floating in your body. So I have never given dexmedetomidine in labor analgesia. It is a very good drug, very good adjunct. But because it causes hypotension and brady, it has never become popular. Clonidine and dexmedetomidine in this country. Number two, we don't have preservative-free, but Ireland uses quite a lot clonidine in the neuraxial analgesia for labor. But in UK, we have used clonidine intrathecally, but epidural we have never used. It's not licensed at the moment. Rate of epidural infusion, we don't use infusion for labor analgesia. The labor analgesia maintenance, I skipped that slide, is we never use any infusion because we have to reduce the amount of total local anesthetic consumption throughout the labor. That is the most important principle of labor analgesia. So what we use is we connect to a pump, and the pump will deliver 6 mils in our hospital, I'm telling, per 20 minutes, and the mother has to press it. So this is called patient control epidural analgesia. Now it is too low dose, so sometimes breakthrough pain happens. So the recent advancement is to use a PIEB, programmed intermittent epidural bolus. What happens is you use 6 mils every 20 minutes, but the pump in an hour will give an extra 7 mils. That prevents the breakthrough pain. But the Singaporeans has come up with a new pump, which is considered now as the best in the world. I haven't seen it. In the literature, it says that it calculates the whole hourly pressing of the mother, and then in the next hour, it changes its, so it gives an infusion to match that sort of labor. So as the labor is progressing, the computer feels that the mother will need more, so it calculates from the previous hour and gives in the next hour a bit more extra. Because the labor progresses, analgesia need increases.
Oh,
so we don't, infusion is in modern obstetric anesthesia, there is no role of infusion, except if you have a PIEB pump, which is a very costly, PIEB special, the Singaporean model pump, which is very costly nowadays. Only 2 or 3 countries have purchased. Literatures are also less, but it is considered as one of the best to prevent breakthrough pain. Is there any role of plain bupivacaine in CS if the patient has MS? It's a debatable thing. Plain bupivacaine, the main problem is plain bupivacaine doesn't spread what you want. In a hyperbaric bupivacaine, you can have 12 to 18 minutes to play with Tendelberg or flexion of the knee and hip. You can still decrease the height by gravity. But plain bupivacaine, no role of positioning, you can't do anything at all. But if you have confidence, you can use it. But plain bupivacaine for joint arthroplasties are very good because they are old patients. Number 2, plain bupivacaine probably causes less urinary retention than hyperbaric. But in cesarean section, there is no, I've never used it, but yes, in India, I've used it, but not in UK. It's not sort of in the protocol at all. Unilateral spinal anesthesia, again, I use, my email address, I think I will, my personal one is, I'm writing it. And the official one, Dr. Ajij and Nimi has it.
Yes, I have it. So
Yeah.
I'll put it
Yeah,
in
you
the.
can share it. I mean, if you
I'll
want.
share it. No problem.
Yeah. Previous spine surgery and neuraxial block. We always consult the patient about two things. One is if it's a laminectomy, I always go for it. If it's a discectomy, I always go for it. But then you can say that can be patchy blocks. We do spine surgery, post spine surgery, epidural spinals. We always do an MRI before, if possible. We do ultrasound, but we always say that it is possible that it may not spread properly. Even nowadays, quite a lot of literature is coming. Interestingly, if you have had a baby 1 year ago, you had a dural tap and a blood patch. Does blood patch changes the next year you come for a spinal? Sometimes the blood gets organized. So there is a very nice book, you can download it. What happens with the failed epidurals? So there was a very clever Australian anesthetist who has written a book, 26 cases, all epidural which failed. He didn't allow to remove the catheter. He gave a contrast and did proper MRI scan, and you will be amazed where the epidural catheters are. So if you have time, it's a very exhaustive book, very difficult book. I read it full, and it is very interesting, and it gives you more insight into what you are doing. So how much is there in epidural and spinal, that area we used to do in India? Like India is the highest population now in the world. So we used to do like 20 spinals, epidurals, I mean, every day. But after reading, I mean, what we used to do in India, now I think I just get shaken. Do you practice epidural with severe MS? Yes, I mean, MS, we always say that it can flare up with a spinal, but still, because of the physiological changes that happen during pregnancy, we still do neuraxial block, but there can be flare up.
Correct.
Okay, very interesting questions. Thank you.
Yes, it was a lovely discussion and lovely presentation. Yes. Very nice. There was one question. I think we have missed it when I was looking for it. When we are talking about mainly labor analgesia and a little bit of neuraxial. So this interesting question comes up. What about segmental spinal anesthesia? Can you give us any guideline on this, or do you practice it?
Segmental spinal, you have seen, I think most of the things have come up from the videos in the YouTube, that they are doing it at T6 for gallbladder, T4 gallbladder, above the conus medullaris, which is at L1 or L2, whatever level you say. Any spinal, it is not done in UK. It's illegal. A lot of papers have come up from India and Europe. They do every spaces, even in pediatric population. No side effects, nothing at all happens. There are few of the experts who are coming in this EURA conference, the National Conference of India for Regional. So I'm one of the invited speakers. I will speak to them what they do, but we are not allowed. But what we do is we have intraspinal catheters, but we can only thread it up to 4 centimeters max in the intrathecal space. I have done a laparotomy, a transverse colon obstruction in a palliative patient advanced cancer. So the interspinal catheter, you can only use hypobaric bupivacaine. You are not allowed to use hyperbaric in a catheter in intrathecal space because of high risk of cauda equina. So we achieved a beautiful level. I mean, she just had a little bit of propofol sedation, and the whole operation was done under interspinal catheter, but done at the L3-4 level.
Yes, there's a center in Italy
yes.
with the Professor Robert Sterner. Yes,
Yeah.
he uses
He uses.
like a
I've seen all the videos, and it's.
spinal.
I
Yes,
mean, it's
yeah,
fascinating. I mean,
right on left. It's
mm,
fascinating. Yes, but
yeah, he does it. I mean, now
he's very strong and very
very. I know.
yeah, very
So
strong
there is
about
one.
it. Anything
There is
against
one.
it, he's very angry.
Yeah, I mean, I never criticize anyone in Facebook or YouTube about whatever they publish, because someday that may be the true thing, because people are thinking so fast. In India, it is used so much. I was
Yes.
shocked. Pediatric population also. So baby, we are doing that, and then we do a permanent nerve damage, but they are doing it and nothing happens. One of my friend does it so much. And I told, if I go to India, just let me do once, just to have a feel. So it will be good.
In Bangladesh, it is also getting a little bit popular, but people are
Popular,
still
yeah.
a little bit hesitant because our teachers and including me, I don't actually like it. So
Yeah, it is. I mean, from traditional people, it is very
yes,
difficult to
it's very
do
difficult to
it. Yeah.
accept. Yes,
Hmm.
very difficult to accept.
But as a
So
registrar in UK, I was doing a thoracic. I was very good in thoracic epidural in India. My fellowship was in cardiac in India, and I was doing it at T6, T4 level, and I did a dural tap with epidural needle. And my my consultant was looking, and he told, nothing will happen, just do it in another space. He didn't scrub. He told, no, you are good, you just do it. So I did it, and I was shocked. I mean, it was a gush of fluid, but it was, I think, T6 or T4. So with the epidural needle, I punctured, like it just went in.
it can
Remifentanil
happen.
PCA for labor analgesia, yes, we have it now, and I have used it quite a lot when I did my obstetric anesthesia fellowship. Um, I don't know. It is a good one. You need a very good monitoring. It gives you intense pain relief, but you have to be using it with pulse oximeter, and sometimes oxygenation is required. It is good for patients who refuse epidural or spina bifida or any spinal surgeries before. It is not. I wrote the protocol a little bit, and I told it cannot be used for intrauterine fetal death. Some centers have used it. It is very, very bad to use it in a mother who has carrying a dead baby, and then you tell them every 2-3 minutes wake up and press. So always use a morphine PCA, which has a more sedation, long acting, and those sort of things are used for even epidurals. We don't allow for intrauterine fetal death, because mother needs to be a little bit sedated, drowsy, a little bit drunk, sort of. That's the philosophy. PCA, remifentanil PCA at one point, Northern Ireland stopped all epidural and only used Remi PCA. The guy who did it, he was quite close to me. We met in a lot of conferences. We used. I trained in a very big tertiary hospital, so we used it. It is good, but I think epidural will still stay. It's not going to go, not to be replaced.
Of course, as you said, it's gold standard in red, but not with the question mark.
Absolutely. Yeah.
Okay, I think we have had enough, and it's getting late here in Bangladesh, and we have a wonderful discussion.
Yeah, thank you very much.
Thank you very much, Dr. Dasgupta. It was wonderful, and we hope to see you again in the near future.
Thank you.
And with some more informations on this peripheral regional anesthesia, because people are getting so much interested in regional anesthesia nowadays.
Absolutely.
That is wonderful to see that young people are doing it. And of course, we'll see you in Oslo.
Yeah, Oslo. I have some family issues. I